I'm excited to be here today to be able to talk to you a little bit about anesthesia, something I'm familiar with, having been a provider for now over 12 years. And in that time, there's been kind of a shift I've been noticing from how we used to do things when we're sedating patients to what's happening now. A few things I've been noticing is there's been an increase in the amount of minimally invasive procedures that are being done. We're doing more and more procedures outside of the operating room theater in areas that are kind of apart, maybe a GI or a TEE or those types of settings. And our patient population is getting older and they're getting a little bit larger. The BMIs seem to be increasing, and with that is coming more problems: obstructive sleep apnea, there's diabetes, there's an increase in heart problems, hypertension. So all of this combined has kind of made it so we're being asked to sedate patients in a deeper way while trying to maintain an airway and work more quickly because there's more procedures. They're wanting to move faster. So they went ahead and they developed this nasal mask, and we call it the Supernova. And this nasal mask, when secured tightly onto the face, is able to provide more positive airway pressure. So they developed this mask, and it can be utilized either with an anesthesia machine, or they've developed what's called a modified Mapleson system, or the satellite kit. When all you need is some oxygen, it already has a hyperinflation bag. There is an adjustable pressure valve incorporated into the elbow, so you can adjust your pressure. There's a bleeder port, so there's not an overpressurization. And what they found was by utilizing this in the operating room, they were able to pneumatically stent open the airway. So what that means is back where the soft palate falls against the retropharyngeal wall, because they're providing this positive airway pressure back there, it's lifting up the soft palate off the retropharyngeal wall, and it's maintaining an airway. And particularly on these patients that are a little bit larger, was obstructive sleep apnea or BMIs, 25, 30, 35, 40 and greater, it was helping to lift up that airway and keep things open. And they found that this was useful, particularly in sedating patients in non-operating room areas. And it helped them to be able to maintain oxygen saturations, increase PaO2, and deliver a deeper plane of sedation more effectively and safely.
I think it's very important to be able to talk about the clinical applications that I've used it for. The first one I'm going to do is because Supernova can be used, both preoperatively, perioperatively, and actually intraoperatively as well as post-op. And so this one case I'm going to talk to you about is where I used it for everything. In this case, it was a 69-year-old male who was coming for a thoracoscopy and lung biopsy. First, they wanted to do a bronchoscopy and then switch over to a double lumen tube to do the thoracoscopy. He was coming in because he kept on desaturating to at least 88% or less on room air, and for unknown etiology. His BMI was 55. He had class 3-4 airway, a large white beard. He had OSA, COPD, hypertension, a very large tongue. So I knew that he was going to be difficult. And my concern at that point was, number one, is I was going to be placing in an 8.0 endotracheal tube, and the second concern was going from an endotracheal tube to a double lumen tube. So what I did is I placed the Supernova on and induced the patient. After induction, I was able to mask ventilate him. Now, if it was a regular full mask, I do not think at all I would have been able to ventilate him at all due to the beard, large tongue. So I mask ventilated him until he was paralyzed and that deep enough for intubation. At that point in time, I intubated him with a glide scope, a video laryngoscope, at 802, which was, with the video laryngoscope, was an easy intubation. Then once they did the bronchoscopy, I now needed to change this over to a double lumen tube. So with the Supernova still on, what I did is I had to use a tube exchanger in order to switch the tubes out. So I put the patient back on the Supernova with CPAP, apnea CPAP. I then placed a tube exchanger into the tube, put the video laryngoscope in place. I pulled out the regular endotracheal tube and placed over my double lumen tube and intubated through there. Through that time, it took about 30 seconds to a minute for to exchange from an endotracheal tube to a double lumen. And the patient did not desaturate one bit. He stayed at 100% the whole time. So then the case was done. Again, like I said, the patient had obstructive sleep apnea. So my concern was him desaturating post-operatively, as I usually do with OSA. So with the same Supernova, I actually placed it on again, hooked it up. At this point in time, I actually use the Mapleson circuit, Mapleson bag circuit that would hook up to the O2 tank for transport. I extubated the patient, and then put him on with the Supernova on and transport him to the PACU, where in the PACU, he, until he was fully awake and was stable enough to switch over to a oxygen mask, this Supernova was kept on. And at that point in time, he did not desat throughout the period of post-operatively as well. So there, I think what this case really is significant about is one that I'm using the Supernova completely throughout the case. Because he is a difficult intubation, he would be a difficult mask ventilation. Also because you have a better seal due to what you have, with the bony structures. And with him, with his mask, which was basically way down here, he looked like Santa Claus. The seal is right underneath the nose so that you actually do get a very good seal on the patient and you're able to ventilate. Again, like I said, for this apneic oxygenation, for exchanging the tube, it was very, very important because otherwise he would have desatted quickly without that.
I noticed a pattern. At first, there was a lot of skepticism from the staff that why would a mask placed over the nose would work? I mean, we always had issues with mask ventilation, specifically in patients that were difficult to ventilate, etc. So then I started seeing a pattern. At first, they were skeptic about the mask. Then I did a demo with them, and then they noticed that it was effective. Then they started liking it. They seemed surprised, but less skeptic. Then they tried it for their own cases. And then they were bigger fans than I was of the whole thing. And to the point that today, then most of our patients, with the exception the ones that are normal size and do not have any coexistent diseases, done with the aid of the mask. And so that was basically, I made everybody I convinced everybody that it will work, but it did not require much effort on my behalf because basically the mask advertised on its own. Basically, when one person started working with it, that person then basically spread the word, and so on, like a brush fire, basically spread on from there. So this has become kind of an essential component of our armamentarium in the airway management of patients that undergoing any non-surgical procedure, usually procedures outside of the operating room. Now, that doesn't stop there, because obviously we'd noticed that there was also a lot of issues in the operating room with difficult mask ventilation. So the episodes that I found with the saturations were no longer happening because the mask is a very effective method of pre-oxygenation. And with the added benefit that also I could use it immediately after extubation and transport the patient with the mask with a simple connection of oxygen and an oxygen tank, and use it also in the recovery room, which basically saved us a whole lot of time when the patients are in the recovery room because they don't desat, and therefore they spend less time, and that implies decreased costs, et cetera, et cetera. So it has become an integral component of our airway management.